Healthcare Problems and Political Solutions, presented by Dr. Edward Harshman. We have to remember that there are many myths and many strong feelings and many emotionally charged statements that we make and that we hear. The first thing to remember about healthcare regulation is that it is often a hidden tax. Insurers force price discrimination on us. Someone who has Medicare or Medicaid will pay less for the same service than someone who has private insurance, and whoever has private insurance may wind up paying less than those who have no insurance at all. Medicare is legal price fixing for the elderly. This is the same kind of price fixing that is commonplace in communist countries, and often with the same results. Low Medicaid payments encourage doctors, nurses, hospitals, and others to raise their prices against better paying customers. This forces the doctors, hospitals, and nurses to become tax collectors. Providers will default to charging more from the privately insured and the uninsured because they can and because they feel underpaid otherwise. This situation is unfair to the uninsured. If healthcare establishment needs tax money at all, then it should be earned from the healthy people and not from the sick people. Sick people can, in general, not earn as much as healthy people, so the burden would be less if it was the healthy people who paid the tax. People who entered healthcare with genuine compassion and a wish to help other people will be particularly strained by the need to act as tax collectors. But we have to remember that annual physical exams and other things like that are not insurable. They're not. They are predictable expenses that have to be paid for. But they are not unpredictable things for which one can rationally design an insurance policy to protect against. Price negotiation, yes. Insurance against an unpredictable chance event, no. To prevent discrimination and cost shifting, insurers will be forced to offer their negotiated prices to all patients who are willing to pay and for all providers who are willing to accept their rates. This way, you could go to the Medicaid office and say, what does Medicaid pay for that surgical procedure that I really need? Okay, I will pay you in the Medicaid claims office that amount plus a service charge, and you can pay the surgeon. If insurers have to offer their reduced prices to anyone who pays them, then there is no price discrimination. Everyone pays the same. The prices will then become realistic. The price to the uninsured will go down because an uninsured person can always go to the Medicaid office and pay the cash price, and then Medicaid will make the payment, and Medicaid will act as the price setting bargaining agent. This process will enrich Medicaid and possibly Medicare without the need to increase taxes. Let's take a look at the dual reimbursement model. The distinction between goods and services is wrong, and as I will explain later, the difference between the entire macroeconomic analysis is wrong. If you hire a taxi to take you from one place to another, that's a service. If you buy a car, that's a good. But there are various rental contracts and leasing arrangements that make the distinction between a good and a service very difficult. Not only is it difficult, it's irrelevant. The important distinction when one is trying to do an economic analysis is not goods versus services. It's low overhead versus high overhead. Somebody who works cleaning houses like a personal janitor, as a low overhead job. Not very much money or training is needed for somebody to decide to do that and do it well. An astronaut has a high overhead job. Not only does the astronaut need to be trained, but rockets and rocket launchers and other things need to be built. The high overhead jobs require major expense to create the job, and the effects of the expense last for years. Build a factory, the factory building will probably be around in 50 years. If you build a rocket or a space shuttle, that's going to last quite a while. The people with the high overhead jobs are not necessarily paid well. It is the cost of creating the job and the commitment to an expense that will last for several years that is most important. No one is going to invest in a high overhead job except if the investor expects that the job will exist until the useful life of the investment has ended. You don't build a 50-year factory building if you expect to produce certain things in it for only 1 year and then you don't know what's going to happen next. There's a need to plan ahead. Medical education is similar. If there is a threat by government or by insurance or anyone else of hard bargaining which will pull down the cost of reimbursement, then people will be afraid to enter medical school and spend the money on the investment. People will be afraid to build doctors' offices, hospitals, medical equipment, and other things if the possible reimbursement in the future is going to be only the variable cost, so that whoever made the investment will lose the fixed cost. If that happens, then there can be a shortage, a major shortage of medical providers and medical equipment that can take several years to correct. There could be a surplus in one decade and a shortage in another. Smart people who understand this reasoning will be scared away from healthcare. And the profession is being dumbed down already. We need a structure for how to pay for health care now that we know that the goods and services distinction doesn't work. Suppose you are a physician and you are offered a fee-for-service contract by a local employer. That means if you get many patients, everyone pays a fee, lots of revenue, so you are happy. But if few patients show up, then you get very little revenue and your overhead may make you lose money. So this may make you a little bit uneasy if this contract is the only offer you get. Now suppose instead you were offered an HMO kind of a contract, a fixed fee. That's so much money per patient per year for a group of people. If everyone stays healthy, that's good. You don't have to work very hard, your overhead is paid for, and you make a handsome profit. But suppose there's an epidemic. Suppose there's a major disaster. What happens then? You get very busy, and you may lose money because of all the variable costs. Now, what you could do is accept both offers, and if the demand from the HMO and the demand from the other employer go up and down at the same time, then in general your overhead will be paid, and the harder you work, the more money comes in. If the ratio is correct between the fixed cost reimbursement and the variable cost reimbursement, then you have no financial risk whatever. So if one looks only at how doctors and nurses and hospitals and such should be paid, we can infer that the way to minimize the financial risk to the doctors and such is to arrange for them to receive fixed cost by a fixed fee arrangement and variable cost by a variable fee arrangement. any departure from that and the expected value of what the doctors and such will want will be higher. So if we follow this process, this protocol, we can minimize the risk. This says absolutely nothing about where the money is to come from. That's a second question, and it's a very important one. Investors, ordinary patients, etc., can sign contracts to pay a fixed fee monthly in exchange for a finite amount of care at variable cost only. Care that is paid for and not needed can be given to charity or to the uninsured and the uninsured poor. The right to purchase such care can be designed by insurance companies, cooperatives, or pretty much anyone. This analysis allows shrewd patients to buy health care scripts and maybe even make a profit from them. There is no reason not to allow such speculation. If you take note of airplane overbooking, in which passengers can take payoffs in exchange for surrendering their reserved seats, that's an example of damages paid to a customer. Now let's take a look at insurance and technological improvements and the decision of do you live or do you die. The life-death decision is very important. It should not be assigned to the government with its death squads. Only the patient can make that decision. And if the patient cannot make that decision, then the patient should ask for some help from a higher power. Not the government, but God. Health insurers are trapped by changing risk. If you buy a house and you insure it, you pay a premium every month. If you buy a car and you insure it, once again, you pay a premium every month. If you buy a bigger house or a more expensive car, the risk, as assumed by the insurance companies, goes up. And so do the premiums. If medical technology improves, the amount at risk goes up, but the premiums don't. You're going to have a very unhappy medical insurance company. So what patients need to do is say, here is the level of service that I want insurance to cover. If there are any new changes in what's available, it's okay if they're not covered. I really don't want my premiums going up. I'm willing to let things alone. If heroic measures to prolong life of someone terminally ill are expensive, it's not the taxpayer's duty to pay for it. If you bought insurance, the insurance can pay for it, and if not, then you have made a conscious decision that such expense is not worth it. You make that decision when you're young and healthy, and you live with it later on. The responsibility should be individual and personal and should not be delegated to the government. This is a time when I have to tell most citizens you are selfish. You can't tell the government to look after you, and having done so, avoid making the decision. The one-size-fits-all insurance policies are just plain unreasonable. Different people have different religious beliefs, different expectations as to how vigorously they should be kept alive. Tax subsidies for the poor may be a good thing, but let's make sure that they are explicitly identified as such. It may be that certain people who cannot afford the premiums for the insurance to provide care late in life should receive some help paying the insurance premiums. That's a political decision, but it should be made out in the open, not disguised. Now let's take a quick look at pre-existing medical condition. and the problem with insurance. Unlike life and death, this is actually very easy to solve. The increase in premium that results from having a chronic condition can be translated by standard financial calculations into a lump sum. An insurance company can either take a large premium from you, or if you bribe it once with a very large amount of cash, it will be content to have a small premium. When you stop being insured from a company and you have a large premium, then the insurance company and you have a pre-existing condition, then the insurance company is going to be very happy to get rid of you. It should pay. It should pay the insurance company that takes over. Then insurers will not be so quick to harass chronically ill patients. They'd have to pay if the patient stops getting insurance from them. Meanwhile, the insurance companies will be perfectly happy to take on chronically ill patients because they know that they will be paid a big lump sum if they do so. Let's take a look at research can be pulled out of politics completely with one very simple rule. Pay only for results. Don't pay for the progress that is intended to lead to the result, or the researchers will simply arrange for perpetual progress and will not get anywhere. Investors can look at a non-revocable promise to pay $50 million, $100 million, or some other large amount in exchange for an answer to a medical problem. Then the investors can hire whomever they wish at their own risk, and when the result has been found, the problem has been solved, go claim the money and save money. First, pain management and opiates. Many people have chronic pain. They require such things as hydrocodone, oxycodone, morphine, fentanyl, and other very addictive drugs. The Drug Enforcement Administration does not and cannot offer rigid guidelines as to when such drugs should be prescribed, because not all pain can be traced to objective physical findings. So if the DEA says it is okay to prescribe to patients who have this and that presentation, then the drug addicts and the drug diverter street dealers will fake those symptoms and the drugs will be prescribed. So the Drug Enforcement Administration has had to provide vague guidelines and an atmosphere of intimidation so that doctors are frightened. That's a real pain. What can be done is to take various combinations of inert ingredients, and with 10 different inert ingredients that can be added in low or high concentrations to a hydrocodone pill, for example, it is possible to code the pills so that they can be traced to one patient, just in case a patient turns out to be a drug diverter. They can be traced, and whoever diverts the pills can be arrested. Maybe this is worth it, maybe not. Now let's take a look at attacking waste. Misuse of healthcare due to social failure, the inability to socialize, to interact with people, to merit having someone nearby who can listen to what you say, the ability to speak, be heard, listen, and interact in a friendly, social way. Some people don't have that or they lose it. Perhaps half of all internist visits are preventable if patients take social needs to their friends instead. People often complain to psychiatrists and psychologists about how they don't have social confidence. If they could learn the skills and get the competence, the confidence would follow naturally. Psychiatric disorders are often classified into Axis 1 and Axis 2. The Axis 1 disorders, anxiety, depression, psychosis, the person who has them is unhappy about them and wants to get better. Axis 2, conduct disorders, histrionic, borderline personality. It's always the other person's fault. The person with the Axis 2 diagnosis really does not have a motive to improve. If we impose swift and sure discipline, rebukes, scolding, ostracism, then the people with the Axis 2 diagnoses can be forced to face their problems, and they will either get better on their own, or they'll have Axis 1 diagnoses that they will want to get better and can get better. Now let's look at drug representatives. People say, why are the drugs so expensive? It's important to look at the drug representatives as an important fact as to why. Drug representatives come around to hospitals and to medical students and internal medical students, interns and residents, and bring gifts full of cheer, very good lunches, and put on presentations without disclosing any prices, and develop a corporate culture within the hospitals that is extremely friendly to representatives. Curious and critical medical students and interns and residents will be discouraged from asking technical questions. It's part of the corporate culture, and it's a very dangerous one. Now let's take a look at cancer screening. Longer survival after a cancer is detected is usually a scam, because the extra life it has to do with how early the cancer is detected, whereas at the same benchmark, it doesn't work that way. Take note of the Mammogram Paradox. This is a very important commentary on human behavior and on the male and female situation. Breast cancer can be prevented with 99% or better effectiveness. Bra time restriction. Charisma is a fraudulent concept. It exists, but if you see or hear the word as a description, somebody is lazy. Whoever speaks or writes should identify the specific behaviors that elicit the charismatic response. To protect against bad relationships, people need to be taught in schools to seek details that cause charisma. A charismatic person may be perfectly honorable after surviving the screening. Let's take a look at how medicine can be made better, not just cheaper, with appropriate changes. If the FDA interference is removed, many natural supplements, herbs, and so on can be marketed honestly and save us some money. We need a way to assess health concepts that is not censorable by the FDA or medical boards or specialty boards or anyone else. Let's use the internet. Do not worry about minor radiation. The linear hypothesis has been disproved by the radioactive cobalt skyscraper in Taiwan and by the lower cancer rate in Denver than at the sea level in the USA. Asbestos has been falsely accused of being dangerous. Intravenous hydrogen peroxide is illegal, it's safe, it's effective, it belongs in ambulances for first aid treatment for people who've had heart attacks, strokes, or other circulatory failure. You can't do it, against the law. External counterpulsation legal, but not in ambulances. FDA, more problems. Statins, expensive, big controversy. Do they help, do they not? But if you really want to reduce the risk of death from heart attack or stroke, put good-sized house numbers so the ambulance driver can find you in a hurry. No side effects. Iodine, omega-3 fatty acids, and large doses of sea salt are often extremely effective at curing chronic fatigue. That is one of several medical facts that deserve circulation and should be in the schools. Dyslexia has been solved. Attention deficit hyperactivity has been solved. Fish oil is the nutritional half of the solution, and avoiding cognitive dissonance is the behavioral half. Interlocking ownership. Now, this is an unpublicized barrier to healthcare reform. Of course, the drug companies and insurance companies will resist healthcare overhaul, but so will many other corporations. If most of the stock of a corporation is owned by pension funds that own stock in drug and insurance corporations, then the stockholders will tell the corporations to self-sacrifice so that the total value of corporate assets to the stockholders, not just the company in question, but the total value to the stockholders of all the companies, will have to be maximized. So what should the government do? Put the citizenry first and tell the fund managers to consider selling the drug and insurance stock. Then there will not be such a barrier for people who say, oh, but my investments are going down. We also have to take note that pension funds and such would be much politically important if we get rid of the income tax, and then there won't be a need for pension funds. There won't be a need for IRAs. People could hire fund managers for their own investments, but the need for that would be much less. Watch out also for corporations that want the high cost of healthcare to remain the same so that they can strong-arm their workers into accepting very low rates of pay. Big labor, unions, same problem. Now let's take a look at education. Schools need to teach the fundamentals of physical examination, home remedies, what to do if there is this and that minor injury, and other health-related issues. A school child is more likely to be confined to a wheelchair than to be a professional athlete. Why are football teams so common and wheelchair sports so rare? Somebody's not planning ahead. Continuing medical education keeps physicians up to date. But what is its content? If health material is useful for physicians, then there should be a way of getting it approved as continuing medical education that is not based on ivory tower approval. If the American Medical Association has any involvement with the approval process for continuing medical education, then you have to expect the pro-AMA bias in the material that is approved and that is taught. Adult education should be available in public schools for people who want to learn how to take care of themselves. I found it difficult to offer such a course. And finally, let's take a look at disability examinations. They are quite reasonably expected for medically impaired applicants, but the examiner is not allowed to tell anything that has any diagnostic or therapeutic consequences to the applicant. This means that someone who is insured and can't afford a doctor visit, or who happens to go to a doctor who isn't very good, may be permanently disabled for life. That's a lot of misery and a lot of tax dollars. Closing credits.